Hi, my name is Pauline. My presentation today is about our experiences in 3D whole heart MR imaging in paediatrics. The MRI department is based in the Royal Hospital for Children in Glasgow. The Scottish Paediatric Service is also based here. Within our department, we scan around 128 cardiac scans a year, and 18 of those are GA scans. We have two MRI scanners, a 1.5 Tesla Avanto and a 1.5 Tesla Era. 3D whole heart imaging is routine in our scans. Around 80% of our patients will have this examination. But recently, they wanted to start up a 3D printing service within the hospital. Therefore, we required some really good quality images to be sent. However, we found some of the images were suboptimal. We weren't sure at this point why it was happening, when, and how often. We conducted an image review, 10 patients scanned within the last year. We initially found that the scans took a very long time, on average from 15 and even up to 20 minutes. This resulted in poor quality images. As you can see on the left-hand side, we're not able to visualize the anatomy properly, and there's quite a lot of blurriness and motion artifact. The main issue was that these images weren't poor all the time, and we didn't understand why it was happening. Could it be the sequence, the readover, or a combination of both? In this slide, we have an example of a GA patient that was scanned over a period of 3 years. In 2017, contrast was used. Although the aorta is imaged clearly, the overall heart image is blurry. In 2018, no contrast was used. Again, we could still see the same issues in the previous year. In 2019, there's a slight improvement in the quality of the image. Again, no contrast is used. But as you can see, the aortic arch is not visualized clearly. To identify if the sequences used were causing image issues, a further investigation of the protocols installed on the scanners were conducted. To simplify this, I investigated where the various protocols used were categorized by age. The Avanto scanner is mainly used for GA scans. Therefore, only two protocols were used there, a GA and a non-GA. Typically, GA scans are used for children who are of 5 years and under. On the Era scanner, there was a single protocol for the age of a teenager. Therefore, when it comes to sizes and some sequences, they were adapted when needed. For example, for a GA patient who was 2 years old, if they found that the field of view was too big, this was adapted to be smaller. Overall, the parameters between the scanners were the same. In this next slide, my colleague Catherine Coyle is going to describe her experiences with scanning with paediatric patients.
So firstly, we need patient compliance, which can be tricky for some of our paediatric patients. We need the patient to keep still and not fidget. As cardiac MRI is not a quick scan, this can be particularly difficult for wee ones, especially after a long period of time lying in the same position. Next, we need our patient to have regular and not erratic breathing so that the respiratory navigator works effectively, and we need good positioning of the navigator too. We need a good shin and the best 4-chamber view to enable us to work out the optimum acquisition to acquire the 3D data set. We will consider doing the 3D sequence earlier during the scan if this sequence is more of a priority.
From our experiences, we need to plan ahead. First of all, we need to consider resolution. Is it appropriate for the age and weight of the patient? Will the data be used for 3D cardiac printing? Do we need to use high-resolution images for this? And as my colleague has mentioned before, 4-chamber imaging is crucial. Do we need to repeat it before the 3D acquisition? As sometimes we can find that patients can get quite restless and move in between scans. Following on from 4-chamber views, we found that the setup for the correct acquisition window was the biggest challenge. From observation, we found that a few staff members found this confusing to do. However, from practice and discussion, we found this helped. From this, we were able to discuss what parameters and what numbers were needed from the 4-chamber view to identify quiet periods of the heart, and what parameters were needed to put into the scanner to finalise the acquisition window. But as you can imagine, in reality, when time is running out and the patient doesn't want to lie on the table, it's difficult to do these calculations. So we found that a window duration of 100 milliseconds was sufficient. For 3D models, the acquisition window in diastole is ideal, but for paediatric patients, usually systole is longer and allows for a longer period of acquisition. We came to the conclusion that we would need two types of resolution for 3D cardiac imaging. First of all, for a low resolution, 1.5 mils would be used, and for a higher one, 0.7 mils. And it was agreed for high resolution at 0.7 mils, it would be used with contrast, as this is something that we use for 3D cardiac printing. And unfortunately, when it comes to cardiac imaging, one size does not fit all, and the field of view would change quite drastically. So when conducting these 3D images, we need to make sure that the field of view is appropriate for the size of the patient. Here are a couple of examples of our low resolution and high resolution 3D cardiac images. On the left hand side is our low resolution. As you can see, it's vastly improved what I had shown previously. And on the right hand side, interestingly enough, without contrast, is our high resolution, and this is the quality that's needed to be sent off for 3D printing. Finally, our wish list. I think that it would benefit in our department to have age and weight dependent protocols, and this would save time and help the radiographer plan their scans. Ideally, we don't want to care about respiratory or ECG gating navigators, and I know there's research out there that we would acquire those images, and this is something that we ideally would need in paediatric. And finally, having short scans. Although that we have overall reduced our time in the scans, something even quicker would be ideal. Thank you very much.